Hi, I'm Chris Jones. I'm the Director of Outpatient Palliative Care at Duke Health. Today, I'm going to talk with you about hospice and palliative care, the similarities, the differences, maybe some myths that you've read online. How does insurance work? I'm really going to try to unpack what could be a complicated topic and make it pretty approachable. I have one disclosure that won't affect anything with today's conversation. So we're going to try to do three things today. The first is understand the difference between palliative care and hospice. The second is to think about how does payment work in these spaces. And the third is to go through a number of misconceptions that people have about palliative care and hospice and try to set you straight, make sure that you understand the truth and not the myths out there. So for our first objective, I'm going to show you the old definition of palliative care. And the old definition of palliative care comes from the World Health Organization in the 1990s. And it says that palliative care deals with the problem associated with life-threatening illness. Folks know what that is? That's death. So we are the death people. We help those who are suffering, those who have physical, psychosocial, spiritual distress. Does anyone want to need this? I don't want to need this, and I do it every day. So this definition really hamstrung our field for quite literally decades. So we have this big branding problem, and this is what I call the dying hands. So if you Google palliative care, you get a lot of one hand that looks old and sick and the other hand that looks well. And we really are at least on the internet, we're the people for the dying. We don't want to be that. So what palliative care did now a decade ago is rebranded the field and took 75 phrases that describe palliative care and asked decision makers in healthcare about these. And who are decision makers in healthcare? People guess doctors and nurses. It's adult daughters. Adult daughters make all decisions in healthcare. So they took all these phrases and put them in front of a bunch of adult daughters, and this is the definition that we came up with. Palliative care is specialized medical care. Everybody loves a specialist for people with serious illness. So no longer do you have to be dying to need palliative care. It focuses on quality of life, so how well you feel, how well you're doing, provided by a team of doctors and nurses and other specialists to add an extra layer of support. If you can rhyme, you do it, so it's appropriate at any age and at any stage of a serious illness. And this is the key, can be provided along with curative treatments. So palliative care really can be anywhere in the spectrum of serious illness. Palliative care is not for the dying at the end. In many places, that's where palliative care grew out of. Generally, it grew out of oncology or geriatrics or hospice medicine, but has really moved further away from dying upstream to try to help people who are suffering. So the initial thought that I had about palliative care, trying to get rid of the dying hands from a branding perspective, is we're medicine's smoke jumpers. These are the highly trained firefighters who jump out of a plane into a wildfire and try to put it out. And it's dangerous work, it's hard work, and you really are in the middle of intense experiences. And as I've thought more about this, I don't want to be a smoke jumper. I think smoke jumping is where palliative care started, when it was in the hospital, in the ICU, trying to help people make decisions about, do I get intubated or do I not? I'm going to propose that palliative care is better thought of as medicine's harbor pilots. So I don't know if you know what a harbor pilot is, but in the complicated harbors around the world, whatever captain piloted the ship up to the harbor entrance. They don't go into the harbor. Somebody joins the ship, climbs on board, and helps you navigate because they've been down that channel thousands of times before. They keep you off the banks. They keep you off the sandy shoals. And this is what I would like palliative care to be thought of. Not added to a forest fire, but brought in when it's pretty clear that the route is going to be complicated. Because those of us in palliative care, we've been down this river before, and our major goal is to keep people kind of off the shoals and keep them as safe as they can be. So if I could bumper sticker palliative care, I would say that it matches treatments to goals. So I never go into a room to tell somebody what they should do. I hear what's important to them. I do my best at the beginning of a visit to sit and listen. And then, once I know what's important to you, try to make a recommendation both about symptom management and about treatments that might or might not help to meet your goals. So this is not who we want to be. We don't want to be the people who come in and give bad news. We'll certainly join along the oncologist or join along the heart failure doctor or join along the pulmonologist to take care of patients with serious illness, but we don't take over. That's never what we want to do. So I'm going to propose, based on the definition that I just gave you, that all three of these people are appropriate palliative care patients. The first one is somebody who has newly diagnosed Hodgkin's lymphoma, probably an 85% chance of cure, but it's going to be hard between now and then. The middle person who's been in and out of the hospital a few times with fluid overload, too much fluid on their lungs from heart failure. And the third is somebody who's 89 with Alzheimer's disease who hasn't eaten a meal in a few days or a week. So if you think of palliative care as quality of life, coming alongside you in a hard situation, all three of these people are appropriate for palliative care. I told you, though, that we're going to think about the differences between hospice and palliative care. So all of these folks are palliative appropriate, but who's hospice appropriate? I'm going to define hospice in the next slide, but hospice really is for people who are in the last 6 months of their life, whose goal is symptom management, whose goal is comfort, quality of life, peace, being out of the hospital. And I'll propose that the first patient who's likely to be cured is not hospice appropriate at all. That person needs chemotherapy. That person needs hospitalization. The bottom person is clearly hospice appropriate. Time is getting very short. My grandmother, who cleaned houses for a living, knows that if you don't eat, you don't live very long. And so certainly number 3 is hospice appropriate. Number 2 is the sticky one, because if the person in number 2 has had a decline in their quality of life, when they get out of the hospital, they're not going home, but they're rather going to a nursing home. They're losing weight. They're short of breath every minute. They may say, I don't think I want to do this anymore. I want to shift my goals. In that case, that person is appropriate for hospice, because hospice is both a quality of care, it's a type of care focused on comfort, and it's also an insurance benefit that brings in a lot of extra support. So if we think about hospice and palliative care, I want you to think that all hospice care is palliative care, but hospice care is palliative care for people who are in the last 6 months of their life who want to focus on quality of life and their comfort. And it's an interesting story. The lady at the bottom right is a woman named Dame Cecily Saunders. She's the founder of the modern hospice movement. And she was in London and first was a social worker, then trained as a nurse, then really wanted to impact the care of the dying on the biggest scale possible, so studied medicine, and realized that each of her trainings impact her ability to care for the dying. And so hospice care is a multidisciplinary affair with doctors and nurses and social workers and chaplains and advanced practice providers like PAs and nurse practitioners and pharmacists and therapists and dietitians, because Dame Cecily realized that no one specialty can take care of the complicated needs of people whose time is getting short. So the thing that I want to make sure is clear is most hospice doesn't happen in a hospice building. About 94% of all days that people use hospice care are in their own home. And home can be defined as a house, a nursing home, an assisted living, but it's the place where you live. There is a bit of hospice that happens in an inpatient unit. The inpatient unit on the right of this slide is Hawk Family Pavilion in North Durham. That's the one associated with Duke Home Care and Hospice. And I think about the inpatient unit like the ICU. You can be sick enough to need to be in the hospital, but not need to go to the ICU. You can have goals and a prognosis that fits with hospice care, but not qualify for the inpatient unit. So the inpatient unit is really structured for people who have uncontrolled symptoms. And I told you that you can be in hospice for 6 months or sometimes even more. The average length of stay in an inpatient unit is about 4.5 days. So very different. Go in, get your symptoms treated, and go back home. Or if time is really short, go in, get your symptoms treated, and die comfortably in the inpatient unit. So the idea here with really all of medical care is that we cure sometimes, we treat often, and we comfort always. And I think that this is a good summary of kind of what palliative care and hospice aim for. If we can fix the underlying problem, we do, but we never lose track of the fact that comfort is important to everyone. So last slide on this topic, just for the visual. So palliative care is the big circle. Comfort-directed, symptom-directed, goals-directed care that can be part of your general medical care if you have a serious illness. And hospice is all of those things, but for people at the last 6 months of their life. So hopefully that's helped people to understand the difference between those two. So we're going to go quickly through the next bit because it's complicated. And the thing that I've come to realize, having been a doc now for 13 or 14 years and having an MBA, is insurance can make up whatever rule it wants outside of the Medicare and the Medicaid system. So private insurers really are the Wild West. What they've come to realize, though, is if you ask somebody about what they want, sometimes they don't want the most expensive thing. And so it's in the insurer's interest to make sure that we understand what patients' goals, values, and preferences are. So by and large, the private insurers will pay for palliative care. And we're going to beat this horse until it's good and flogged. Palliative care is for anyone with a serious illness. Hospice care is for those with the last 6 months of their life. So just as a reminder, palliative care is for anyone with a serious illness. Hospice care is for those in the last 6 months of their life. So these are some examples of plans local. If you're in Idaho, the rules can be different. If you're in Maine, the rules can be different. But pretty much private insurers will pay for both palliative care and hospice care. Humana, Blue Cross, United, pretty much everybody has come up with both a palliative care and a hospice care benefit. But remember, any private plan can make any rule. So you're going to have to talk with your plan to figure out what's covered and what's not. Medicare, which is a bit more structured, has a palliative care visit the same as they pay for any other specialist. So however you see your cardiologist or your lung doctor, you can see the palliative care person. And hospice care is covered by Medicare with almost no deductibles. But what they don't cover is room and board. So if you need to live in a nursing facility, for example, Medicare will pay for the hospice care, but they won't pay for the room and board in the nursing home. So room and board is the bed and the food and being wiped up or cleaned up and your laundry, all those things that would happen at home if you had a family of 20. Medicare doesn't pay for that stuff. But Medicaid in almost every state, for people who've spent down their money, have a low income, will pay for palliative care, certainly, hospice care, and if you qualify for the nursing facility, Medicaid will also pay for the room and board. So Medicare and Medicaid, having both of those really does give the most flexibility. But the take home from this section is if you're in a private plan, you have to ask your plan what they're willing to cover and what they're not. And if you need hospice in a nursing home, the only way to get that paid for, certainly you can private pay, but the only way to have that paid for by insurance, typically, unless you have a really generous private plan, is through Medicaid. So we're going to do the last bit. I mentioned on this slide that we'll have 3 misconceptions. I think I've doubled that, and we're going to do a couple more. So the first is, oh, he's not ready for palliative care. From what I've taught you already, I hope it's pretty clear that if you're ready for symptom management, if you're ready for avoiding suffering, if you're ready for making sure that your wishes get in the medical chart, you're ready for palliative care, because palliative care can be provided, can happen along with any curative care. I've had patients say, "Oh, I don't want to go to palliative care. It'll be too depressing." And that's not actually a problem. When people come to our clinic, they'll very often say, "Oh my goodness, I wish I'd come here before, because you're the people who've really sat and listened to me." And not to rag on any other specialist, we generally have more time because our patients are sicker. When I got a new primary care doctor, they had a 20-minute slot to take care of me as a new patient. I'm very fortunate to have 60 minutes with a patient for a new patient slot, and that's probably pretty standard for palliative care around the country. So we will focus on you. What's important to you is what will be important to us, and we're not going to be the dying people. We really do want to focus on living well. How about, oh, she doesn't want hospice care, she wants to stay at home. I've had a number of patients be really disinterested in hospice because they thought you had to go somewhere. Hopefully I've taught you already that hospice comes to you. You don't go to it, by and large. So the majority of the time, hospice is provided in the place where the person lives. Oh, she's not ready for hospice care because she's not dying. This is a really common misconception, and when I talk about hospice care with my patients, I bring this up even if they don't ask about it. You qualify for hospice if your prognosis is 6 months or less, and you want to focus on symptoms, quality of life, staying out of the hospital. People don't necessarily get kicked out if they perk up. It's a continuous reassessment of 6-month prognosis, and about 10% of people outlive that initial 6-month prognosis. Generally, the biggest problem we have with hospice is people waiting much too late, and then they use hospice in the last 2 or 3 days of their life. And what I always say is, I don't want a stranger in my house if I'm dying, either for me or my family. So using hospice a bit more upstream, you can still get the antibiotic for the urinary tract infection. You can still get the medication for the cough. You don't have to stop medications that are helping you feel better. So don't think of hospice just as the last couple minutes of life, people. I get this one a lot. She's not ready for hospice. She still wants to fight. And I don't for a second think that almost anybody wants to give up. But it's really common for people with an illness to recognize that their body's giving out underneath them. And then you just change the fight. You stop fighting to live to be 110. You start fighting to be outside the hospital, to have your symptoms better managed, to deal with the psychological and spiritual stressors in life. So it's just a different fight. It's not no fight. And I've had this concern once or twice where people think that hospice will kill you. And indeed, hospice does not kill you. Hospice focuses on today. What I say to patients is hospice focuses on making today be the best it can be, and if there's a tomorrow, making tomorrow be the best it can be. So hospice neither shortens your life nor does painful, aggressive things to lengthen it. Really just tries to make each day be the best it can be. So those are our kind of 6 misconceptions. So just remember, you can't get in palliative care too early, no such thing. Palliative care focuses on you, not on some agenda. Most hospice is at home. If you get it before you're actively dying, you and your family will get a fair bit more benefit. And hospice won't kill you, which hopefully will make people feel better. If you want to get hospice or palliative care, if you're on an inpatient basis, you can ask the doctor or nurse practitioner or PA taking care of you to see if there's palliative care in the hospital you're in. If you're outpatient, you're in the Triangle area, Duke Palliative Care's phone number is here and Duke Hospice's number is here. And then if you're outside the Triangle, since this is a national presentation, this is a resource that can help you to know what palliative care organizations are in your local area. And I have one more tip in the minute or so that I have left, and this is so often people who care about someone who's sick or their family, they come up and they grab you by the arm at church or at the grocery store and say, I heard John is sick. I'm so sorry. Let me know if there's anything you need. So what I encourage families to do is have a notebook with all the things you need written down. And when somebody who you know means it offers that, give them a very specific request. And here's an example one. Can you come and sit with John every other Thursday? You might even say, and bring a bottle of wine for you and I to share after I get back, because I'm going to go out and take a walk and do some grocery shopping. If someone wants to be generous, this is a way that they're very able to be generous. And I think if someone says to you, I care about you, let me know if I can help, and all of our natural response is to say, I'm okay, I'm okay, I'm okay. You're not okay. So have your list of things that you need, things that don't bring you joy, the load of laundry, cleaning the bathroom, running out for groceries, and be able to send that to somebody who wants to be helpful to you. That's my last little tip. Here's our summary. The big circle is palliative care. The little circle is hospice care. Don't wait too late for either. Generally, palliative care and hospice care are paid for by insurances, but Medicaid is the only one that'll pay for the room and board in the nursing home. Don't believe the myths. And when people say, I want to help you, but they don't have the words to offer something specific, be ready for them. Be ready to allow them to be generous. Thanks so much.